Good evening. I'm Dr. Tejveer Singh. I'm a medical oncologist out of Reno. And I'm very happy to welcome you to the Nevada Oncology Society fall meeting. As some of you may know, Nevada Oncology Society is a chapter member of the ACCC. And if you're a member, you have access to exclusive ACC resources, which I find very useful in practice management. And NOS members also receive discounted registration for ACC events, which are very educational. I would also like to thank our corporate sponsors. First and foremost, our platinum premier members are Bristol Myers Squibb. Then platinum members are Grail and Merck. And gold members are AstraZeneca, BeiGene, Daiichi Sankyo, Excellis, Genentech, Incyte, Lilly, Novartis, Pfizer, and Regeneron. So we have two very good speakers today. One topic is updates in gastric cancer surgery, and the second will be by Dr. Toscano on the management of relapsed diffuse large B-cell lymphoma. So the first to go will be Dr. Tuttle, and he will be speaking on updates in gastric cancer surgery. And this will be a virtual talk. And we can start whenever you're ready.
Hello, everyone. Can you hear me okay?
Yes, just, we can.
All right. Well, I will do the mandatory screen sharing. All right. Can everybody see my slides? I hope so. Well, I am a surgical oncologist at the University of Minnesota, and I really appreciate the opportunity to be here. I'm really getting sick of Zoom meetings, and I'd hoped to have been in Reno for this meeting in person, but I had made a commitment for a previous trip. Tonight, I'm going to be talking about updates in gastric cancer surgery. I have no financial disclosures. Throughout this presentation, I will be referring to NCCN guidelines, but I will also offer my own jaded opinions free of charge. The reason I can't, oops, I am not moving it. The reason I cannot be with you tonight is I'm in Honduras right now. I'm about an hour north of Tegucigalpa at that star. This is a beautiful country. The photograph on the right lower part of the screen is what it looks like. I'm on an orphanage that's on about 2,000 acres of land. It looks like Montana. So for the past decade, I have been seeing patients and doing cancer surgeries here in Honduras on those in need. And the photograph on the left is our new clinic and operating rooms. I'm actually in this building right now. This building is on the orphanage here in Honduras. The building on the right is our newly built visitor center and conference center. So we have been holding various educational events for Honduran nurses, staff, physicians over the last couple of years. So I hope your meal at the Whitney Peak Hotel is good. I'll be eating rice and beans after this presentation. So I think that the most important update in gastric cancer surgery is that the survival rates have improved after surgical resection for gastric cancer. And a few years ago, we published the results of a study we did using the surveillance epidemiology and the end results database in the US. We looked at 5 different time periods and found that the most recent time period, shown in pink from 2008 to 2013, was associated with an improved overall survival rate. When we performed a multivariable analysis, we found that young age, Asian ethnicity, no lymph node metastasis, and recent year of treatment were all independent predictors of improved survival. So this is very good news. How did we get there? Well, I think there's a number of reasons why the survival rate has improved after surgery for patients with gastric cancer. First is that more patients are receiving effective perioperative chemotherapy today. And I could spend the whole 45 minutes talking about the intergroup trial or the MAGIC trial, but that would take the entire time. Instead, I'm going to focus on other possible reasons why the survival rates have improved, including better patient selection and improved surgical treatment for gastric cancer. Let me start first with patient selection. These are the NCCN guidelines for the workup of a patient with gastric cancer. They're very extensive, as you can see. I think the 3 most important components of a workup of a patient with gastric cancer are: 1, a very detailed history and physical. These patients are often older, often have extensive comorbidities. The surgery is a difficult one to recover, and we want to identify those patients who are most likely to benefit. Secondly, a high quality CT scan of the chest and abdomen and pelvis is mandatory for the evaluation before treatment. Our oncologists like the use of a PET CT scan if patients are going to receive neoadjuvant chemotherapy. And finally, we'll use laparoscopy and cytology for staging for gastric cancer. So before any treatment, we recommend an outpatient laparoscopy. So if we do a laparoscopy, we find this obvious tumor nodules in the peritoneum, we biopsy them, prove they're malignant, and the patient receives palliative care. On the other hand, if we perform laparoscopy and it looks like this, it looks stone cold normal, that's great, but we're not done. So we perform peritoneal washings, collect the fluid, and perform cytology. And about 5 to 10% of these patients who have a normal laparoscopy will have occult positive peritoneal cytology. And the survival of these patients with occult peritoneal metastasis is dismal, as shown in this graph. So by performing laparoscopy and laparoscopic cytology, we can prevent an unnecessary or futile operation on 5 to 10% of patients who are clearly not going to benefit, thus improving overall survival rates. Next, I want to talk about improvements in the surgical treatment of gastric cancer. The first successful gastrectomy was performed by Theodore Bill Roth in Vienna in 1881. This portrait was obviously completed before the pandemic because no one's wearing masks, no one's wearing any headgear, no one's even wearing gloves, and yet this operation was successful. So sometimes for gastric cancer surgery, less is more. So consider a patient with a distal gastric cancer. Does this patient need a total gastrectomy? With our to a subtotal or a total gastrectomy, there was no difference in overall survival between these 2 treatments. A French study showed very similar results. So a subtotal gastrectomy has a lower complication rate, it has a lower mortality rate, and improved quality of life. I just got a message that my internet's unstable. So if I do go off, I've asked the IT people to send me a text. Sorry, we'll slow down and start over. Less is also more for gastric cancer surgery when we consider the spleen and pancreas. Previously, when patients had gastric cancers involving the greater curvature of the stomach, we recommended a splenectomy in the performance of a distal pancreatectomy. However, the performance of a splenectomy and distal pancreatectomy do not improve outcomes. They only increase postoperative complications, and also they increase perioperative mortality rates as well. Other times for gastric cancer, less is just less. Let's consider lymph nodes, one of the most controversial topics in the management of gastric cancer. We often debate whether a patient with gastric cancer should have a D1 lymphadenectomy, which is removal of the perigastric lymph nodes, or a D2 lymphadenectomy, which is removal of the perigastric lymph nodes, plus the lymph nodes, the branches of the celiac axis. The most discussed randomized clinical trial ever done in gastric cancer surgery is the Dutch D1 versus D2 clinical trial. This study was enrolled patients from 1989 to 1993, 80 centers. Patients had adenocarcinoma without distant metastasis, and they were randomized to either a D1 or a D2 lymphadenectomy. Now, at this time, the Dutch surgeons did not really have any experience with a D2 lymph node dissection. In contrast, the Japanese surgeons, where the incidence of gastric cancer is much higher, had a lot more experience. So this trial went to great lengths to try to have high quality surgery. So they had booklets, videotapes. They flew Japanese surgeons in the operating room for on-site operating instruction. They had supervised operations, multiple meetings, and they studied, throughout the study, they studied lymph node number and determined whether or not there was non-compliance or contamination. So very high quality randomized clinical trial that was conducted many years ago. The results were initially presented in the New England Journal of Medicine with a 6-year median follow-up. The study found that a D2 lymphadenectomy was associated with an increased perioperative morbidity and mortality. The overall survival, as you can see, was not significantly different. There was a non-statistically significant decreased risk of relapse for a D2 lymphadenectomy. The authors concluded in 1999, our results do not support the routine use of a D2 lymphadenectomy. So we're done, right? Well, they continued to review their data, analyze the results, and then they published the results again. Now with a 15-year follow-up. Again, the upper curve, you can see no difference in overall survival. But now the lower curve shows a significant improvement in gastric cancer specific survival rates with a D2 lymphadenectomy. So now the Dutch say that we believe that a D2 resection should be recommended as the standard approach to resectable gastric cancer. This is an unusual finding in that at 6 years, there's no difference. At 15 years, there is a difference. It's unusual to have a gastric cancer recurrence between years 6 and 15, but these are the data. So what's the NCCN recommend? Presently, the NCCN recommends a D1 plus D2 lymph node dissection, preserve the spleen and pancreas as we've talked about, and in the performance of the lymphadenectomy to remove and evaluate at least 16 lymph nodes. So where did this number of 16 come from? Well, there are a number of different studies using different databases that have shown that the removal of 15 or more lymph nodes is associated with improved survival. So for instance, in the study by Schwartz using the SEER database, the evaluation of 15 or more lymph nodes was associated with a significant improvement in overall survival. So perhaps the main benefit of a D2 lymph node dissection is just to remove more lymph nodes and potentially more microscopic disease. Well, we use this 15 or more lymph node number as a quality metric for gastric cancer surgery. So in our study using the SEER database, we found that the proportion of patients who had at least 15 lymph nodes evaluated significantly increased during the 5 time periods of our study. And interestingly, the proportion of patients who received guideline recommended 15 lymph nodes or more parallel the same trends that we saw in survival. So perhaps the observed improvement in overall survival after surgery is partially due to better surgical technique in removing more lymph nodes. Additionally, improved survival is probably also secondary to a decrease in the postoperative mortality rate. So Shannon and colleagues recently published a study using the National Cancer Database and found that the 90-day mortality rate after a total gastrectomy decreased from 14% in 2004 to 7.9% in 2015. This is a substantial decrease in mortality rate. So if you can have an almost 7% survival benefit just by having a better surgery, that's going to impact long-term survival rates as well. So in this study, there are a number of factors associated with the higher mortality rate after a total gastrectomy, including older age, low volume facility, more on that later, higher end stage, less than 16 lymph nodes again, and no chemotherapy use. So why have we made improvements in reducing postoperative mortality after gastric cancer surgery? I think part of it is better patient selection. I also think that our surgical techniques are better. We have lower leak rates, less blood loss, and I think there have been improvements in perioperative care. Antibiotics, critical care, and nutrition is very important. Next, I want to talk about what advances between laparoscopic and open gastrectomy for patients with gastric cancer. Let's look at a couple of randomized clinical trials. The CLASS trial with a C was from China, and patients with distal gastric cancer were randomized to either a laparoscopic or an open distal gastrectomy with a D2 lymph node dissection. No difference in overall survival. The CLASS trial with a K from Korea similarly randomized patients to either laparoscopic or an open distal gastrectomy. Again, no difference in overall survival, no difference in cancer-specific survival. A meta-analysis of 17 randomized trials found no difference in lymph node evaluation or severe complications between laparoscopic versus open gastrectomy. And although laparoscopic gastrectomy was associated with longer OR times, there was less blood loss, earlier return of GI function, shorter hospital stay, and less anesthetic requirements. The authors of this study recommend that laparoscopic gastrectomy is superior to open gastrectomy for gastric cancer patients. So let's go back to the NCCN. What do they recommend? So minimally invasive approaches may be considered for selected cases. The surgery and the surgeon must have experience in laparoscopic or robotic foregut procedures and lymphadenectomy for gastric cancer. And this is kind of hard to do. There are traditional fellowship trained surgical oncologists like myself who are very experienced in performing a D2 lymph node dissection, but have had little experience in laparoscopic or robotic foregut procedures. And likewise, there are bariatric surgeons who have extensive experience in robotic or foregut procedures, but no experience with lymphadenectomy for gastric cancer. So we have a little bit of a problem of finding a surgeon who can do both of these well. And this problem is quantitated by this recent study from the National Cancer Database that was published over the summer. They looked at US hospitals. Less than 8% of gastric cancer patients were treated at high volume centers. As I mentioned earlier in the presentation, treatment at a low volume center was associated with a significantly increased perioperative mortality rate. So that's the problem that we've had. We have had trouble for decades of trying to regionalize complex cancer surgical care. But we have seen an important development recently. Just 2 weeks ago, this study was published in the Journal of Clinical Oncology, which I think is a landmark study. This is a study from the Kaiser Permanente Northern California group. And in 2016, they regionalized gastric cancer surgical care from 19 centers before 2016 to only 2 centers after 2016. And then they compare the outcomes pre and post regionalization. And I think the results are pretty dramatic. So post regionalization of gastric cancer surgery was associated with an increased use of neoadjuvant chemotherapy, a marked increased use of D2 lymphadenectomies, more minimally invasive gastrectomies, more patients who had at least 15 lymph nodes evaluated, and a decreased hospitalization. I think these results are very dramatic, and I think this is going to hopefully be a practice-changing publication. Additionally, in this study, they found that the 2-year survival was also significantly improved after regionalization. Next, I want to talk about the surgical management of patients with gastric cancer metastasis. The most common site of metastasis outside the stomach for patients with gastric cancer is the peritoneum. And this is a very difficult site to treat, as you all know. There has been increasing chatter in my circles about the use of cytoreductive surgery plus hyperthermic intraperitoneal chemotherapy for patients with gastric cancer. And surely cytoreductive surgery plus HIPEC have been used for ovarian cancer, colorectal cancer, appendix cancer, mesothelioma. But does this treatment make any sense for patients with gastric cancer? There have been a number of multi-center registry studies published, and this is the latest one, and the results are similar to other publications as well. This is a study from Italy. 91 patients presented with synchronous peritoneal metastasis from gastric cancer, and they underwent extensive surgery plus HIPEC. The 90-day mortality was 6.6%. The median overall survival rate was 20 months. If you look at this survival curve, you look at this recurrence-free survival curve, you can see that nearly everyone recurred within 1 year. And this seems to me, and this is a selected group of patients. These aren't all comers, because only patients who had limited disease actually underwent surgery. Let's look at a study from the US. This is a single center case control study from MD Anderson. Again, patients with synchronous peritoneal metastasis from gastric cancer were treated with chemotherapy, and then if they did not recur, they either underwent laparoscopic HIPEC or they had palliative care. No difference in overall survival in this selected group of patients. The authors noted that HIPEC is an investigational regional therapy. Periscope 2 is a prospective randomized trial that's being conducted by the Dutch. In this trial, again, patients with synchronous peritoneal metastasis from gastric cancer receive several rounds of systemic chemotherapy. And if they do not progress, they're randomized to either continued chemotherapy or cytoreductive surgery plus HIPEC. We anxiously wait the results of this randomized trial. The NCCN currently indicates that HIPEC may be a therapeutic alternative for carefully selected patients in the setting of ongoing clinical trials. So my advice to the oncologists in Nevada is do not let your surgeons put hot chemotherapy into your patients' bellies without having an IRB approved clinical trial at your institution. All right, so far I have been talking only about gastric cancer treatment. What about prevention? This is Napoleon. Napoleon died of gastric cancer. Napoleon's father, grandfather, 4 sisters, 1 brother, all died of gastric cancer. Medical historians believe that Napoleon and his family had a CDH1 mutation. Clever medical historians argue that the reason that Napoleon's hand is on his stomach like that is because he had chronic gastric pain and eventually had gastric cancer. These are the current NCCN guidelines for genetic risk assessment for patients with gastric cancer. These are pretty confusing. Personally, I just offer genetic counseling for all patients with gastric cancer and let them decide whether or not they want to undergo any testing. There are a number of conditions, syndromes associated with gastric cancer. We think about 3 to 5% of gastric cancers are associated with an inherited predisposition. The most common is hereditary diffuse gastric cancer, which is associated with a germline truncating mutation in CDH1. The lifetime risk for men is about 70%. For women, it's about 80%. Women are also at increased risk for developing invasive lobular breast cancer as well. So for patients with CDH1 mutations, a prophylactic gastrectomy without a D2 lymphodissection is recommended somewhere between ages 18 and 40. So in summary, the survival rate for gastric cancer is finally improving in the United States. This is due to multiple factors, including the increased use of effective perioperative chemotherapy, improved patient selection, improved lymph node evaluation, and decreased postoperative mortality. Laparoscopic and robotic gastrectomy have important advantages over a traditional open gastrectomy, and I think that recent advances in regionalization of complex gastric cancer care may make this possible in the future. And I would argue that you should consider genetic testing and identification of hereditary gastric cancer in your patients. I want to thank you so much. And if there is time and ability, take any questions. And I am thankful that this worked on the internet here in the middle of Honduras.
Anybody has any questions? Yeah. Dr. Tuttle, can you hear us?
I did not.
Oh, okay. Why didn't you come here and then? Yeah. Robin here. Oh, yeah.
So I said that CDH1 is associated with diffuse type gastric cancer. And I was wondering if you could address the survival or mortality of gastric surgery in diffuse type versus intestinal type gastric cancer, please.
That's a very good question. So the diffuse type of gastric cancer is associated with a worse survival. It tends to be more proximal, but it can involve the entire stomach. More frequently, it has to be treated with a total gastrectomy, even if you don't have a CDH1 mutation. The intestinal type has a better prognosis. It is more often distal and can often be treated with a subtotal gastrectomy. So getting a diagnosis of a CDH1 associated gastric cancer is a terrible diagnosis. It's really hard to screen patients with this condition. We do it, but oftentimes, even with random biopsies, we cannot accurately send with
Any other questions?
You've shown an impressive reduction in post-op mortality, but I'm wondering of the ones that are still dying, what are they typically dying from?
Just a second, we lost them all together.
Oh,
there may have been another question. I just briefly lost internet, but I think I'm back.
Can you hear me?
Yes.
Okay. You demonstrated a very impressive reduction in postoperative mortality through the recent years. I'm just wondering, what are these patients typically dying of now?
I think postoperative pulmonary complications are probably the biggest one. And I think we're doing a much better preoperatively of identifying and maybe treating those patients. And I think our SICU care is much better. Patients still have MIs. We still have leaks. I had a patient that died a couple of years ago after a total gastrectomy from thromboembolism of her entire superior mesenteric vein complex, and her bowel just died for unclear reasons. But I'd say probably the number one cause is still pulmonary complications.
we have another question.
Can you tell us what the prevalence or how common it is dumping syndrome after gastric surgery?
Thank you. Yeah, it's a pretty common it's a fairly common problem. It can be mild, and I think that most people will have it. It can be mild, and it can be relatively easy to manage. In some patients, it can be devastating, and I think that's a very small proportion of patients that it becomes devastating and it really impacts their life. And really getting those patients ready with a preoperative nutrition consult and postoperative nutrition consult really help with in creating expectations and in managing the symptoms they have afterwards. But it's still pretty common. There are a lot of most of my presentation this evening has been on early postoperative complications, but the long-term complications are also fairly significant and remain significant even today after surgery, particularly for a total.
All right. Dr. Tuttle, I had a very simple question. Is there a cutoff between high volume and low volume centers? The volume of cases or per surgeon?
Yeah. So in the NCDB study, they had it at 17 procedures per year. That was how they defined it, and they had some reason for doing that. I think somewhere probably between 15 and 20 is probably a good number to use. But it's important. It's not just the surgeon that impacts mortality. You can have a very high volume surgeon working in a low volume institution, and the outcomes are likely not going to be very good. And so I really think you need both. But in the NCDB study, they had it at 17, and they dichotomized between high and low. You'll see other studies that will have it in quartiles, the volume, but I kind of like the way they did in that study.
Any more questions? I think we're done, Dr. Tuttle. Thanks for this excellent presentation. It was very, very good.
Thank you, everybody, for putting up with me. Have a good evening.
Program at University of California's Davis Cancer Center. He's also the DeLune's Endowed Professor of Medicine at the same university. And Dr. Toscano will be talking about the treatment of relapsed refractory diffuse large B-cell lymphoma. Dr. Toscano.
That's okay. I'm all right. All right. Thank you so much. Thank you for inviting me. I love Nevada. So I spend actually a fair bit of time here. Ruby Mountains. I love the Ruby Mountains, which are fantastic. I love to backpack. I usually try to incorporate a few photos from the various trips. I like to consider them hematologic retreats. So this is Patagonia a couple of years ago. So what I'm going to talk about tonight is relapsed diffuse large B-cell. So diffuse large B-cell lymphoma is the most common hematologic, malignancy. And lately, there's been a lot of new agents that have been FDA approved for relapsed aggressive lymphoma. So it can be kind of confusing right now on what to choose, when to choose them. I'll give you a lot of information. I'm not sure, absolutely sure it'll be crystal clear when I finish, but because we need comparative trials. But hopefully we can have some discussion. It's good to discuss some of these things, and please ask questions, stop me anytime. Let me see if this works. I'm a little too fast. Nope, not yet. Well, my next slide will say, there it is. 7 new agents approved for relapsed refractory diffuse large B-cell in the last few years, 3 different CAR T-cell products, and 4 additional targeted agents. So how do we integrate these? Is there still a role? So most of us that treat a lot of lymphoma will agree that the standard of care for upfront treatment is still R-CHOP. It actually, I'm going to talk about this in a little bit. It may not be much longer after ASH this year, but right now it's R-CHOP for the majority of patients. And in my opinion, it's dose-adjusted R-EPOCH for double hit lymphomas. And it's a little bit controversial for double expressor lymphomas. I use a lot of EPOCH as well, but R-CHOP is still the relative standard. So that component is relatively straightforward, except in certain populations, like the high-risk populations, as well as maybe elderly patients. And we could talk about that as well if you'd like. But in the relapse setting, pretty much the standard of care is salvage patients. Oops, sorry. It's probably my children wanting money. That you generally salvage patients and then you take them to auto transplant, although that is evolving as well. So, auto transplant used to be the standard. Is there still a role for allogeneic? We used to use allogeneic for patients that had failed auto transplants in certain subsets of relapsed diffuse large B-cell, particularly primary refractory patients. So a lot of new agents. There's more coming, and there's a whole plethora of bispecific antibodies coming as well, and bispecific CAR Ts. So a lot of stuff happening in oncology in general. I applaud the general oncologists because it is really challenging for me to keep up in heme malignancies, let alone all of oncology. So I am in awe. So these are some of the FDA approved agents. This is the real Matterhorn in Zermatt, Switzerland. We hiked there a while back. So we have Polaritus. It's been around for a couple of years now. It binds to CD79B. We're going to talk about that. The next one is Lanka Cetoximab, which binds CD19. It's an antibody drug conjugate like Pulatuzumab. We have Tapacidomab, which is a humanized engineered antibody. We'll talk about that. And then we have selinexor. So we're going to talk about all of these, a little bit about CAR T, try to put them together a bit as well. So we'll first start with Polaritus. So Polaritus, FDA approved for relapsed diffuse large B-cell in combination with bendamustine and rituximab. Polaritus is very much like brentuximab, which is one of the first antibody drug conjugates, something that we are used to using for Hodgkin's lymphoma, T-cell lymphoma. And it binds to CD79B. CD79B is an accessory molecule. It's basically on all B cells. It's internalized once it's bound. And it has this MMAE, monomethyl auristatin E. You're going to be quizzed on that later. So that's like a very potent vinca alkaloid, very like a very potent vincristine. And it has this VC linker, same thing, again, with brentuximab. And so it's internalized. It's cleaved and released inside the cell to minimize systemic toxicity. So that so it's a very it's not really that innovative, primarily because brentuximab paved the way now for many, many years. And when you give it with or without rituximab down there on the bottom, about 50% of patients respond. But really, there weren't that many complete remissions. And there were some phase 1 data combining it with bendamustine, and they saw some pretty good results. And so there was this large randomized phase 2 trial. So they added it to bendamustine rituximab and compared it to bendamustine rituximab. We think about bendamustine primarily for indolent lymphoma, and it is FDA approved for indolent lymphoma and CLL. We use it quite a bit there, but there is pretty good data for aggressive lymphomas too. And I like to use it. It's a little bit of a different mechanism, and we could talk about that if you want. Has a bendamidazole. It's kind of like a alkylator and a purine analog. It's pretty interesting. Developed in East Germany, kind of hidden until the Iron Curtain fell. So it's a very old drug. Anyway, I won't belabor all those points. I can get bogged down sometimes and distracted. So you have to kind of realign me back to diffuse large B cell. So what do we randomize phase 2, Pola BR versus BR? The primary endpoint was a response, a PET determined response. And this is the outcomes. The red bars are the Pola BR, so 45% overall and 40% CR. So that was pretty darn good in this patient population. Most had been heavily pretreated. And you could see that the bendamustine by itself, the BR, it really didn't do very well. I was a little surprised by that in this trial. Other trials have shown anywhere from 30 to 40% of patients will respond, but not the 40% CR rate. So that was pretty good. Progression-free survival was much better for Pola BR, median about 10 months. And surprisingly, overall survival was better. So you rarely see that. Median follow-up was around 22 months. So you don't see benefits in overall survival that soon, generally, unless it's very, very effective, especially if you allow crossover in those trials. This got FDA approved, and it's been FDA approved. And I use it quite a bit in the relapse setting, trying to get patients to transplant, allo, or CAR T. Although there is some debate because it does have T cell suppressive effects. And in fact, bendamustine there is now some data suggesting that you need to use PJP prophylaxis for these patients because of the T cell suppressive effects. So there's some belief that you need to use, that you don't want to use this before CAR T, but that's still debated. So now, because just like with everything, we move it up front once we have it approved in the relapse setting. So this was a phase 1b/2 trial in previously untreated, and added to CHOP, dropped the vincristine. The RCHP, so that's very much like what was done with what we call the Echelon 2 trial. The Echelon 2 trial was in relapsed T-cell lymphoma, and it was CHOP versus brentuximab CHP. And there was a big overall survival benefit for that. And so this is kind of the same approach. Drop the vincristine so you don't get accumulative neurotoxicity, and then add the antibody drug conjugate. And you could see response rates were pretty incredible, 77% complete remissions. And you could see that progression-free survival was very, very good. So that led to this large randomized trial, the POLARX trial. So R-CHOP versus POLA-RCHP in the previously untreated diffuse large B-cell lymphoma. And it made a late-breaking abstract for this year at ASH, and I believe it might be presented at the plenary session. So that's a nail biter. So we expect there to be some big news. R-CHOP has been the standard of care for many, many, many years, and it may change. So we'll see. Pretty exciting times. So now we'll move on to the next targeted agent. That's Lanka Cetoximab. And this is an interesting agent for a couple of reasons. Number one is it binds to CD19. But also it's an antibody drug conjugate with a biodegradable linker, but the toxin is different. So MMAE is used quite a bit. And so this has the PBD, the pyrrolobenzodiazepine dimer. Okay, it sounds like a anxiolytic, but it's not. It's a very, very potent alkylator, and it binds irreversibly. So very, very potent alkylator. So it's unique in that sense. So it was given the first 2 cycles, 150 micrograms per kilogram. It was dropped down to 75, and then it was given for a year. Cut to the chase, the overall response rate was 48%, and the CR rate was around 25%. Median number of prior regimens was 2. The important thing about this trial, it allowed all comers. And that's what you really have to look at when you're looking at this data. You want, how does this translate to my practice? And so this, in the sense, was all comers. So patients that had failed an auto transplant, patients that were primary refractory, those are the hardest patients to treat. So included all of those patients. And in fact, this is the breakdown. And this is, I think, somewhat telling in the sense that if you looked at patients with double hit, triple hits, double expressors, or not double expressors, the response rates were still pretty good in the 30 to 40% range. Patients that were primary refractory as well, they still responded. Patients that had failed CAR T or patients that had failed auto transplant responded about the same way. So anyway, this is a good drug for patients that have failed a number of regimens, including auto transplant. Well, they can, yes, but also you can use this as a bridge to CAR T too. And there is some data that shows that that if you go in, and there is some concern about this because all of our CAR T products target CD19 as well. So a lot of people would be worried if you're resistant to this drug, are you going to lose CD19? So there is really no data for that. There is data though in patients that fail CAR T. Up to 20% of those will develop resistance by modulating CD19 expression. So actually, I have a CD19 targeted trial, and if they failed CAR T, I require a rebiopsy to make sure they still express CD19. So I would do that here, but the reverse isn't necessarily true. It hasn't been shown with these other targeted agents that their resistance is due to CD19 modulation. So we don't know that, and we do know that patients that fail this agent can go on to CAR T and still respond. So does that answer your question? Okay, Good. So this is the duration, the durability. And again, so about 12 months, 13 months if you had a CR, it's pretty good. Again, for this patient population. So this is the median overall. You take all comers, the median progression-free survival is around 5 months, overall survival around 9 months. Oh, and so can I go back? So this is the data again. So some of those patients did go on to transplant, and some of them did go on to CAR T-cell therapy, and about 50% of those patients responded to CAR T-cell therapy. A little bit lower than what's been seen, but not dramatically lower. And then the toxicities, just going to focus on these, the ones, the treatment emergent grade 3 or greater, some neutropenia and thrombocytopenia, but a relatively small percentage of patients, GGT and some anemia. But again, very few patients came off study due to toxicity. So a pretty well tolerated drug. So now we'll move on to the next agent, Tapacidomab. And this is an interesting drug, and for the reasons, a couple of reasons that I think it's interesting anyway. And one of them is that the CD19 component, the binding region of the antibody, has been engineered. So what's done is to you introduce mutations, just exactly what's going on in our germinal center. It's called affinity maturation. That's how our antibodies increase affinity, by introducing mutations into the variable region of the heavy and light chains to increase affinity. So the same thing was done with this antibody to create an antibody that binds more avidly to CD19. Do we know that that increases efficacy? We don't for sure, but there is some suggestion it might. Then also what was done is that the FC portion, and this is the business side, was engineered to increase FC receptor binding. And that has been shown to increase effector cell activation, okay, and recruitment. So that's how rituximab or most humanized antibodies work, is by recruiting host immune effector mechanisms that have FC receptors, NK cells, monocytes, maybe some T cells. And if you have increased affinity for that FC receptor, you get better efficacy. At least that's the theory. That's what was done with obinutuzumab. Okay, and that's why obinutuzumab potentially is a little bit more effective, and it makes it a good partner for immune modulators as well. So they were able to show that there's increased ADCC, antibody-dependent cell-mediated cytotoxicity, as well as antibody-dependent cell-mediated phagocytosis. So these engineering, at least in vitro, it was able to show that there was some enhanced effects by making these changes. So it's a unique antibody for those reasons. In terms of the L-MIND study, so this is in patients with relapsed diffuse large B-cell. We all know that it's an unmet need. We need less toxic agents. A lot of patients aren't candidates for auto transplant. And is there an alternative? I mean, some patients aren't candidates for CAR T as well. So is there a candidate? Is there an option for those patients? And also there were some early phase trials in CLL and relapse diffuse large B-cell and follicular that showed as a single agent, there was some efficacy. We also know, and this is something I have a lot of experience with, is the combinations of lenalidomide and antibodies. And in fact, Revlimid and rituximab was first developed at started those trials 15 years ago, and I still have patients in remission, relapse refractory patients for 15 years that have follicular lymphoma. So anyway, the idea here was to combine it with lenalidomide. So lenalidomide is going to enhance those host immune effector mechanisms to make the antibody work better and utilize that engineered FC portion of the antibody. The important distinction, you can't, and for some reason this is blue, you can't read this. So these are patients that were a bit more selected than in the Lanka Cetoximab trial. And those patients are not auto transplant candidates. Also, they're not primary refractory patients. So you have to kind of keep that in mind. We always teach our fellows, don't make cross-trial comparisons. We need to avoid that. But when you don't have any comparative trials and you're trying to choose a drug, you have to kind of look at what is the patient population that they use this in, and is that similar to the patient I'm thinking about treating it with. So anyway, so this was done. The Tapacidomab was given weekly initially for the first 3 cycles with lenalidomide, and lenalidomide was given at 25 milligrams a day, days 1 through 21. And then it was the Tafa was given every 2 weeks. And then eventually, if they responded, were doing well after a year, the lenalidomide was dropped. And these are the patient characteristics. Again, this is the median age, so it's actually an older group of patients, 72. These are all the classifications. I'm not going to go over these in detail. Prior transplant, just a small percentage of those patients had a prior auto transplant. This, for some reason, these slides aren't coming up, but this is the overall response rate, CRs and PRs. You can see that initial evaluation was 57%. And then the CR rate was 40%. So that's pretty good. The duration of response was very good, about 3 years. Median progression-free survival was about a year. And then if you looked at only those patients second line, so a lot of people might think, well, if I have a patient that isn't a transplant candidate, then that's going to be second line, right? Because you're not going to salvage them and take them to transplant. Then maybe this might be a good drug for those patients so that you aren't going to take to transplant. If you look at just second line patients, which is that next column, the my pointer's not working. The overall response rate was 67% and the CR rate was 50%. Durability was about the same, about 3 years. So that's pretty darn good. So if you look at a little bit longer follow-up, we like to look at the longer follow-up. You can see the overall response rate held true at 57%. And the durability was around the same, about 34.6 months, median progression-free survival, 12 months. And that's that second column under the blue tab there. The median overall survival was 31. That's very, very good. And these are the progression-free survival or the duration of response curves. And you can see that the patients that had a CR are doing very, very well. And even patients that have a PR. If you look at progression-free survival, you can see the progression-free survival is very good. Is there a plateau on that curve? Maybe. We'll have to wait and see. And again, these are aggressive lymphomas. These aren't indolent lymphomas. So those patients generally, especially relapse patients, generally progress pretty quickly. And this is a longer follow-up looking at overall survival. So you can see that patients that had a CR, doing pretty well out. And you can see that a high percentage of patients that at 12 months, 98% remain in CR at 12 months. That's pretty darn good. This is the toxicity. You see on the left is the combination. And so you see a lot of cytopenias, quite a bit neutropenia. And you can see that the grade 3/4s are the dark purple and the whatever that is, burnt orange. You can see quite a bit of neutropenia, anemia, and thrombocytopenia, but not terrible. And some diarrhea, asthenia, other side effects, edema. But then if you look over on the right, those are patients that have just on the Tapacidomab have dropped the lenalidomide. So you can see a lot of the toxicities go away once you get rid of the lenalidomide. So that's where a lot of the myelosuppression comes in, the diarrhea, rashes, things like that. We're all used to using lenalidomide now. We know those toxicities all too well. Okay, so now we'll move on to the fourth agent that was FDA approved. And this is, it really has been FDA approved for a while, and this is approved for myeloma. And so there is some phase 1 data in patients with lymphoma. So this is a trial in relapsed aggressive lymphoma. And this is an interesting drug because it's a brand new mechanism of action. It inhibits exportin, which modulates nuclear export. So it can modulate tumor suppressor genes. It can modulate P53 and IKB and FOXO as well. Very interesting to me, MYC, BCL2, BCL6. So that becomes very important in those double expressor lymphomas potentially. So this is the patient population, de novo transformed, primary relapsed and is given 60 milligrams twice. A lot of people don't like to give selinexor for myeloma because it's relatively toxic, but it is given at 80 milligrams twice a week. And now there's some data using it weekly, maybe with bortezomib, and there are exploring other schedules to make it a little less toxic. But this is a little less toxic because the dose is a little bit lower. 127 patients were enrolled, 67% the median age. Again, de novo, relapse, and transform. Median number of prior regimens is 2, with up to 6 regimens. So this is the overall response rate. It's kind of hard to see here, but it's 28%. You might say that's not very good, and 12% CR is not bad considering the patient population. And then stable disease around 10%. You'd say, why do I care about stable disease? It is important in diffuse large B-cell lymphoma, but in fact, patients that had a PR, the median overall survival was not reached at a median follow-up of about 22 months. And the median overall survival was 18 months in patients that had stable disease. So that's pretty remarkable, 18 months with just stable disease. So yeah, it's a pretty interesting drug. So you get more stability as opposed to responses. So this is the duration of response. You can see for all responders around 9 months, for CRs around 13, and for PRs around 4.8. So these are the AEs. Again, thrombocytopenia, neutropenia, anemia, fatigue, hyponatremia, and nausea. And these are some of the ways we all know how to mitigate or deal with those side effects. If we work on oncology, that's for sure. This is the infamous waterfall plot. So you can see that there are a lot of patients that derive benefit that may not meet the criteria for response. Almost just as many derive some benefit. And those are all the patients that would be considered to have stable disease. This is pretty interesting. This is a subset analysis, and this is really what interests me. And if you look at patients that had failed a transplant, relapsed within a year of a transplant, the response rate went from 28 to 52%. So that's pretty interesting to me. I've never seen anything like that. So exactly the opposite of what you would expect. And I have a theory. Maybe we do know that double hits, double expressors don't do well with auto transplants. So we do know that. That's been shown by Alex Herrera. And so maybe there's a high percentage of those in this patient population. I don't think it's been looked at though. So let's move on now. I'm not going to give you the whole rundown. I don't have time to give you the entire rundown of CAR T cells, but this is the overview. So these are the 3 FDA approved CAR T cells. So I have the Kite product, the Axi-cel, and this one, the overall response rate's 84%. CR rate is around 58%. Median follow-up is 27 months. There's a little longer follow-up as well. And then this is the CRS, 11 and 32%. And these patients that get into CR, there is the potential for durable remissions. And so the longer term follow-up that's out after more than 2 years shows probably about 40%, upper 30s to low 40s will remain in remission for more than 2 years, and some of those patients may be cured. So that's pretty exciting. That's similar to what was seen with Kymriah and the ALL, the pediatric ALL. That's what we have the longest follow-up for CAR T is in pediatric ALL, and that's looking around 30% long-term. But those are kids that have failed an allo transplant. Those are the worst patients. So anyway, the data is looking good for Axi-cel. Tisagen Lecu-cel is the Kymriah. That's the Kymriah product, FDA approved for ALL as well. And now it just got FDA approved. It was just for young adults and children with ALL, and recently got FDA approved for adults with ALL as well, but also approved for relapse refractory diffuse large B-cell lymphoma. Overall response rates a little bit lower. The CR rates a little bit lower at 40%. Again, not comparing. These trials were very different. And I'll talk about selection bias in a minute. And then we have Lysocell JCAR product. This is a BMS product. It's a little bit interesting. What they do is These are all comer T cells that are transduced with the construct to create the CAR T cell. The same thing is true with the JCAR, but then there's subsets. There's a proprietary selection of CD8 and CD4 positive T cells, a magic ratio that nobody knows what it is, to try and enhance response and reduce toxicity. And you can see that the responses are good, comparable, and you can see that the CRS and the neurotox is a little bit less with this product. Again, they have not been compared head to head. And I'm not going to go over all the details, but bottom line is that it's now the Axi-cel is approved for follicular lymphoma as well. We could talk about that if you're interested. There's a similar product. I think it's really the same thing. It's approved for mantle cell, relapsed mantle cell as well, Tecartus. And then there's a couple other products coming as well. All kinds of combinations. PI3 kinase inhibitors, BTK inhibitors, checkpoint inhibitors, lots of combinations that are being presented at ASH this year. And then now, and finally, there's a couple of randomized trials that are comparing CAR T to auto transplant in the relapse setting. And just so happens, word came out today that one of them made the plenary session. So you have to expect some big news there at ASH this year. So a pretty exciting ASH. So maybe some practice changing, especially for lymphoma. So can alternate therapies compete? And when you think about this, you think, well, what about all these treatments I just mentioned? Well, they haven't been around long enough really to compare them, or to really to compare them to CAR T cells. And this is not a direct comparison. This is just looking at a retrospective analysis, looking at responses and durability in patients that got alternative products. So alternative products in this setting would be things like ESHAP or ICE, auto transplant, Aloe transplant, all of those things. So that's the comparison. So when you look at the outcomes in terms of overall response rate, CR, and then the 12-month progression-free and the 12-month overall survival, it's still better for CAR T cell products. But still, I think to make a valid comparison, we have to wait a little bit longer. And we need direct comparisons, prospective randomized trials, like the one that's maybe going to be presented at ASH this year. So what about outcomes in patients treated with commercial CAR T? So this is something I've always been a little bit leery of, is that for, whenever you put patients on clinical trials, these are heavily selected patients. These aren't necessarily the patients that we see in practice. The patients on trials are highly selected. We see elderly, beat up patients that don't have good social situations, don't have good counts. All of those are controlled for in clinical trials, especially CAR T cell trials. Because CAR T cell trials, number one, you have to be selected. You have to be able to go to a major center. Number one. Number two, you have to wait to get on the trial. You can't have had treatment for a period of time before the trial, and that's not too easy with aggressive lymphoma. And you have to wait. Your disease has to be controlled during the manufacturing process. And back then it was about 4 weeks. Now it's down to about 3 weeks, so 2.5 to 3 weeks. But still, so that's a selected patient population. So I've always wondered, well, what happens when we take it out into the community, not on a clinical trial, especially when we have a soft heart and somebody has a bad disease and we want to offer them potentially curative therapy. We're going to put anybody that we could put on there on the trial on a CAR T cell product. So they looked at that, and the red is the CAR T, and the other one's the other. And you can see it's still better. For the left is progression-free survival, and the right is overall survival. And then this is the top left. The A is second line. So you can see that the CAR T is still better. The next one over is third line. You can see, you still see a plateau on that curve. And then the one on the bottom, the C, is fourth line or greater. So you can see those patients in the alternate treatment are not doing too well. Whereas the CAR T, they aren't doing great either, but still better. So the important thing here, though, is that the patients that did go on to auto or aloe transplant, who did 56% eventually relapsed. So those that did not. So there are some patients that do go on to auto or aloe transplant that can be cured. So I think the dilemma is that once you get somebody, are they a candidate for auto transplant? We'll talk about that a little bit more. And then you treat them with CAR T. When do you go to something else, a different agent or a allo transplant? So that's the important question. So again, this is more real world experience, looking at patients in the real world outside of a clinical trial. And here they looked at, on the top, they looked at performance status, or LDH, I believe. This is performance status. So you can see if your performance status was 0 to 1, that's the top curve. You did pretty well. And the red curve is the lower performance status 3 or 4. So those are that's the left is progression free, and on the right is overall survival. Down below is the LDH. So if your LDH is low, you do well. If your LDH is high, you do poorly. So patients, again, with a good performance status and low tumor burden tend to do better with CAR T, and that's what we'd all expect. But there are some patients with primary refractory disease that do have durable remissions after CAR T. And that I was telling the fellows, I always try to educate the fellows. I do a lot of that. And so it's a kind of a tough call right now. You have somebody with diffuse large B-cell lymphoma that doesn't have a great performance status, let's say, and they aren't a candidate for an auto, or they failed an auto transplant. When do you throw in the towel? When do you go for CAR T cell? And so even patients with a high tumor burden and a poor performance status, you can still more challenging to know when to give up. Whenever we send our patients to the ICU says, okay, goals of care time. It's time for the goals of care talk. I get so tired of that. Well, we haven't tried CAR T yet. This guy, there's no way you can't cure him. Well, we do have CAR T cells. So it's a bit of a difficult time right now, I think, to make those decisions, when to throw in the towel. I always have that trouble, that a hard time anyway, but I think with these kind of products, it makes it even harder. So now I'll just touch on allo transplants. This is the Marble Canyon, not too far from here in the northwestern corner of California. It's really a beautiful, kind of one of the first national parks in California. And so this is a trial looking at reduced intensity conditioning for relapsed diffuse large B-cell lymphoma. And you can see that the overall survival out 6-8 years is around 45%. It's pretty good. The relapse rate, again, around 40%. But the important thing is the non-relapse mortality is pretty high, 25-30%. I think we've gotten better at that. I do have some trials looking at allo transplant for relapsed diffuse large B-cell, and I've salvaged a number of patients that otherwise clearly would not be alive with allo transplant. So those patients that are young, good performance status, that you can control their disease. You have to be able to control their disease. And you can find a donor. And nowadays, we do have a much easier time finding donors because of haploidentical transplantation. So almost everybody has a donor now. And now we're doing allo transplants on people that are fit in their 70s pretty commonly. And there is data for that as well. You might think I'm crazy, but there is data. This is another separate trial giving really consistent results, again, in relapsed diffuse large B-cell lymphoma, around 40% long-term survival. Again, these are selected patients. And also you see that steep part of the curve, 20-30% are dead right away. And again, that's the upfront non-relapse mortality. So this is the overall schema, I think, for relapsed diffuse large B-cell. So these are patients that have been treated, most of it with CHOP. About 60% of patients will be cured with our CHOP. So that means about 40% will relapse. 10 to 15% are primary refractory. Those are the toughest patients to treat. Around 50% will be eligible for a stem cell transplant. Of those, about 50% will go to stem cell transplant. And those that get it, about 40 to 50% will have long-term survival. So overall, of all comers, around 20 to 25% of all comers relapses will be cured with auto transplant. But again, that remains the standard of care. For those patients that either aren't transplant eligible, they relapse after transplant or don't make it to transplant, we do have a number of options. We have CAR T, and most of us would say getting those patients to CAR T is the number one priority. And how do you do that? What do you use for salvage? There's a lot of treatments now. We can use any of the targeted agents that we talked about tonight, as well as the chemotherapeutic regimens that we're all used to. We tend to try not to beat them up. We try not to use T-cell suppressive agents prior to CAR T. Do we know if we should use CD19 targeted agents prior to CAR T? We do not. So I don't use that as an exclusion. So I think Tapacidomab, Lanka Cetoximab, maybe even selinexor, Pola BR, I do use it. And there is a paper that came out showing that you can use it prior to CAR T. If you're worried about the bendamustine, you can still get pretty good remissions with Pola rituximab by itself as well. Again, around 50% of patients. And then you have their cells collected, and then those patients will need bridging therapy while their cells are being manufactured. So we'll send them back to the primary oncologist and ask them to give them another cycle or two while we're manufacturing those cells. So that's really the overall schema, I think, for relapsed diffuse large B-cell lymphoma. A few other things I wanted to touch on. Bispecific antibodies, this is the next wave. This is the John Muir Wilderness. This went up there about 3 or 4 weeks ago. There was no smoke as well. It's pretty nice. So this is, I hate these names, Mosunetuzumab, Nccn. It's a CD20, CD19 bispecific. Some really good data with that. Overall response rate around 37, CRs around 19, but you can see a lot of patients benefit that don't meet criteria for complete remission. And then some of those are durable. So 17 patients, about 70%, 17 patients achieved a CR, about 70% are in remission up to 16 months later. And again, when you're in remission for more than a year or two, that's a good sign for diffuse large B-cell lymphoma. So these are all the bispecifics that are being developed. Mosunetuzumab, Oduronextumab, Glofitamab, and Epcoritamab. The one that's probably going to be FDA approved probably within the next year is Glofitamab, and that's good because that's the easiest. A lot of trials, and I finish up with this one. This is a phase 1 trial that I'm the PI. It's open all across the United States, sponsored by your tax dollars, the NCI. And this is blinatumomab. So blinatumomab is a CD19, CD3 bispecific that's FDA approved for relapsed ALL. And we combine it with lenalidomide. So we thought about those combinations long ago, bless you. So this is our schema. We give blinatumomab, and then we give lenalidomide, and then we give an induction, consolidation, and maintenance. I'm not going to go over all those details. So of the patients that completed induction, we presented this at ASH in 19, the overall response rate was 91% and 55% CRs. So that was pretty impressive. But we have to always give the obligatory case to emphasize. A 47-year-old male with mantle cell treated with CHOP and auto transplant, relapsed with a lot of disease. And then we put him on our trial, had a complete remission. And then what we did is we took him to Aloe Transplant. The guy's been in remission for now about 4 years, which is pretty cool. So these are some of the novel agents. Most of these we talked about. I think that selinexor needs a partner, and that partner, in my opinion, is going to be something like venetoclax, which venetoclax is now the partner for almost everything. But we've talked about most of these agents here tonight. And so there's some exciting new combinations. You can imagine the number of combinations you can come up with all these agents. So in conclusion, I think autologous stem cell transplant remains the standard of care for eligible patients with relapsed diffuse large B cells. So those are patients, again, probably under the age of 75, maybe older if they're really fit, that have that don't have primary refractory disease, that have a good response, a PR or better, preferably a CR to salvage therapy. So those patients are the standard of until maybe after the plenary session, it may be different, who knows. And then CAR T cell is generally appropriate for patients that have relapsed, that have failed auto, aren't a candidate for auto. So they aren't a candidate. Maybe you don't think they can tolerate high dose chemo. It used to be that the eligibility for CAR T was the same as auto, but we know it's not quite the same. And there's data now for giving CAR Ts in their 80s now. So it is, and actually we're getting better at mitigating the cytokine release syndrome with tocilizumab, if we can get it, and with steroids and early adoption of steroids. Actually, there used to be the belief with rituximab that you didn't give steroids with rituximab because it was going to inhibit those T cells or NK cells. Same thing was believed with CAR T, still kind of is, but there was data now that you can prophylax with steroids and mitigate a lot of the cytokine release syndrome, and the efficacy is the same. So that makes it much, much more tolerable. So anyway, so patients that aren't maybe an auto transplant candidate, fail auto, relapse after auto, those are the CAR T cell patients. Insurance approval used to be very challenging. Now it's getting better. The Medicare is still very challenging because they don't pay for all of it. So Polaritus, selinexor, Tapacidomab, Lanka Cetoximab, all FDA approved. I'm very impressed with Tafa's durability. I think that's very encouraging. We have some long-term follow-up. I think selinexor has some surprising efficacy in patients that have very high-risk disease. But I think it needs a partner personally. Don't be afraid to use it because there is it's better tolerated than the myeloma dosing. And then Lanka Cetoximab, also Lanka Cetoximab, has good efficacy even in high risk, double hit, double expressor, primary refractory, auto transplants, a nice agent to get somebody to CAR T, or maybe an elderly patient that is not a candidate for any of those. So I think that when you're considering salvage therapy prior to CAR T, you can use any of these agents. Use it for bridging therapy after they've been collected, and look for many combinations. And again, I want to reiterate, if you're gotten CAR T and you're going to go with a CD19 targeted agent like Lanka or Tafa, you want to rebiopsy those patients, make sure they still express CD19. And I'll stop there and take any questions. This is one of my other hobbies besides winemaking, is fly fishing. It's a great area here to do that. So happy to take any questions. And then we do have a lot of trials. I know it's a long ways for most of your patients to make it to UC Davis, but we do have a lot of trials for hematologic malignancies, lymphoma, all the different subtypes, acute leukemia, chronic leukemia, myeloma. So I'd be happy to give you my number or my colleague's number to call anytime, day or night. No, I love being a resource for the community. I do. I am allowed to focus. It makes it a lot easier for me. So I'm happy to help out any way we can. So thank you very much.